Good morning, everyone. Thank you so much for joining us today. I think the last couple of people are just logging in now. My name is Kristen Vandenberg, and I'm an associate in Miller Thomson's Health Industry Group. And this morning, I'm joined by Kathryn Frelick, who's a partner and the national lead of our Health Industry Group. And together, we're going to present this morning on some current privacy hot topics for the health industry. So just a couple of housekeeping items before we get started today. First, there are a significant number of participants who are logged on this morning, and so everyone's lines have been muted, and we ask that you remain on mute throughout the session. Due to the number of participants and the amount of material to get through today, we unfortunately will not be hosting a Q&A at the end, and the chat box has been disabled. But we do absolutely invite you to reach out to us following the presentation if you have any questions. And our contact information, it's up right now, and it will be available again at the end of today's presentation. So without further ado, let's take a look at our agenda for today. I'm going to start us off with some background on what has been going on in the health industry in Ontario to bring us to where we are today. Kathryn and I will then discuss a variety of privacy hot topics, following which Kathryn is going to address specifically how COVID-19 has impacted privacy laws in Ontario. And then we're going to finish up, just wrap things up with a brief summary at the end. So let's start by taking a step back to what seems like a million years ago now with the introduction of the Connecting Care Act. So although it seems like a lifetime ago, the one-year anniversary of the Connecting Care Act was actually just last week. It was declared in force on June 6, 2019. Now, as I'm sure most of you recall, the Act established Ontario Health and Ontario Health Teams. So prior to COVID-19, the last year was already a whirlwind in terms of these Ontario Health Teams completing their self-assessments and their applications, developing governance structures, and moving towards implementation of these Ontario Health Teams. Now, I bring up the Connecting Care Act and Ontario Health Teams because one of the main pillars of the Act is its commitment to a digitally enabled healthcare system with improved access to secure digital tools, including online health records and virtual care options for patients. So this is evident in multiple places within the Act. First of all, the preamble itself of the Connecting Care Act explicitly highlights a commitment to a sustainable, digitally enabled, publicly funded healthcare system built to last. The Act also sets out the objects of Ontario Health, which include, among other things, ensuring the quality and sustainability of the Ontario health system through digital health, information technology, and data management services. So Ontario Health Teams themselves, one of their main pillars is being designed to provide improved access to secure digital tools, including online health records and virtual care options for patients, as well the self-assessment and application forms, as I'm sure many of you remember well. They were completed by prospective Ontario Health Teams last year, and they included numerous questions regarding the Ontario Health Team's current digital health capabilities, as well as their plans to improve information sharing and resolve digital health gaps in accordance with provincial guidance. So what provincial guidance, do you ask? This brings us to the government's Digital Health Playbook. As prospective Ontario Health Teams moved through the self-assessment and application phases of Ontario Health Team development, the ministry was also developing and releasing various materials to support Ontario Health Teams, including in respect of digital health. So the Digital Health Playbook was introduced in August of 2019 to help Ontario Health Teams understand exactly how they can build a digital health plan that supports the delivery of integrated care within the Ontario Health Team. The document, which I'm sure many of you have seen, it's quite extensive, and it actually consists of 3 different components. So there's the Digital Health Playbook itself, a digital health service catalog, as well as a digital health policy guidance document. So I'll just walk you through each of those really briefly, just to give you a sense of exactly what they are if you haven't seen them. The playbook itself provides a general overview of the types of tools, requirements, and policy directions that will guide the creation of digitally enabled Ontario Health Teams. and it provides information on the supports that are offered by specific digital health delivery organizations. So these are organizations such as Cancer Care Ontario, eHealth Ontario, Health Shared Services Ontario, and others, several of which of these have already been rolled into Ontario Health. As I'm sure you remember, Ontario Health is going to consist of many amalgamated organizations, including some of those I've just mentioned, or some of which will be rolled in the future. Now, the Digital Health Service Catalog, it sets out a number of provincially available digital health tools and services that maintain either a major regional or a major provincial presence and are available for use by Ontario health teams to satisfy the various digital health needs and requirements. So the catalog is intended to help Ontario health teams understand what tools are available, how they can benefit from particular tools or services, and who they can contact to learn more. So it's a very, very practical tool. The digital health policy guidance is the last component of the playbook, and it's generally a set of policy directions that are going to guide implementation and the use of digital health tools and assets. So the reason I give a little bit of background on this is because it shows that, even before 2020, things were well underway and rolling along with the development of Ontario health teams, a huge component of which related to digital health and privacy. So there are already some big changes in the works there. So in that vein, in late 2019, the Government of Ontario announced its new Digital First for Health strategy. This strategy is based primarily on feedback from Ontarians, and it has three main goals, which are there at the bottom of the slide. The first of these goals is to modernize the Personal Health Information Protection Act, also to improve access to virtual care, and lastly, to promote clinical systems renewal for integrated care. So in its announcement in November of 2019, the province said that once the Digital First for Health strategy was fully implemented, patients could expect to see 5 things. They could expect more virtual care options, expanded access to online appointment booking, greater access to data for patients, so more patients would be able to review their health record online and make more informed choices about their care, better, more connected tools for frontline providers, and lastly, which will be a big thing we talk about today, is data integration and predictive analytics. So providers would face fewer barriers to integrating and using health information to manage health resources and improve patient care. And this is intended to lead to improvements, including earlier intervention and better management of chronic disease. So as you'll see, the amendments that we're going to talk about today, they all will tie back to each of these 5 pillars in support of the Digital First for Health strategy. So what types of changes are we seeing? Most of the changes that we're going to talk about today come from 2 bills, particularly in respect of PHIPA. So there's Bill 138, which was the Plan to Build Ontario Together Act, and Bill 188, which is the Economic and Fiscal Update Act. Bill 138, we talked about it a little earlier if you're able to join us in January for our coffee talk. Most of that came into force in December 10th, 2019. There are still a couple of provisions that are awaiting proclamation and they're not yet in force. And parts of the Economic and Fiscal Update Act, it was introduced this year and it came into force on March 25th, 2020, although there are still some sections of the Act not yet in force as well. In respect of the Freedom of Information and Protection of Privacy Act, there were some amendments brought in last year in respect of data integration, again, which we talked about in January. There were some further changes that were introduced more recently under Bill 188 in respect of data integration, and we'll talk about those a little bit later as well. Lastly, the Child, Youth and Family Services Act. That act was introduced a little while ago. It's from 2017, but there was a Part 10 of that act to do with personal information. And while it has been in the act for some time, it wasn't in force until January 1st of this year. So just to dive a little bit deeper into some of the more recent changes at a high level before we get into the specifics, Bill 188 garnered a lot of attention earlier this year as an omnibus bill that passed many measures in response to COVID-19. most of which were to support the health sector in the delivery of care and communication of important information in the midst of COVID-19. In particular, the legislation had a significant impact on privacy rights via amendments to the Freedom of Information and Protection Act and the Personal Health Information Protection Act. For example, in respect of data integration, and the implications of these amendments will actually reach far beyond the COVID response. So I think it's important to know that although a lot of this was framed in the context of COVID, the implications are much broader, and a lot of these amendments were actually in the works before COVID became as prevalent as it is right now. Now, in addition to Bill 188, there are a number of proposed amendments to Regulation 32404. So that's the regulation under PHIPA. And there were two proposed regulatory amendments, both of which were introduced in May, and they're both open for comment right now until July. So they're still in the early stages. So I encourage you to go take a look at those online. Now, the first regulation deals with digital health interoperability, so the ability of digital health platforms to work together and talk to one another. Right now, there is a very recognized lack of interoperability across provincial digital health assets, and the province has expressed on multiple occasions a commitment to improving interoperability to enable health service providers and individuals to access personal health information in a more reliable and consistent manner, which is what this regulation is intending to facilitate. And we're going to get into that a little bit more later. The second suite of proposed amendments are intended to facilitate proclamation of Part 5.1 of PHIPA, which you may recall are the provisions relating to the Provincial Electronic Health Record. Now, these provisions were first introduced several years ago, but they have not been declared in force. Kathryn is going to talk a little bit more about these proposed amendments a little bit later in the webinar. And so the last thing I wanted to touch on before we move into our top 10 privacy hot topics is the Child, Youth and Family Services Act. I just wanted to really briefly highlight the changes because they're a bit broader than what we're going to get into today, but they do have pretty significant implications for service providers under that act. I should clarify, the act does not necessarily apply to everyone in attendance today. So service providers, as defined under the Child, Youth and Family Services Act, are persons or entities who provide services which are funded under that act. So the paramount purpose of the Child, Youth and Family Services Act is to promote the best interest, protection, and well-being of children. And one of several additional purposes under the Act is to recognize that appropriate sharing of information to plan and provide services is essential for creating successful outcomes for children and families. To that end, Part 10 of the Act, the part that came in force on January 1st of this year, it's essentially a mini privacy code. It sets out rules for service providers regarding privacy and access to personal information. With limited exceptions, Part 10 makes clear that service providers must have consent to collect, use, or disclose personal information. They must also take steps to safeguard this information and must notify people if there's a breach of their privacy. Service providers must give individuals access to their records of personal information on request, subject to limited exceptions, and must respond to requests for correction of inaccurate or incomplete records. So since many of you are health information custodians, these requirements may already sound a little bit familiar to you, and you may be wondering how obligations under the Child, Youth and Family Services Act operate in conjunction with obligations under PHIPA and potentially under PHIPA as well if you are an institution. So Part 10 has considered this, and Section 285 under the Act discusses the interplay of the various legislation. Essentially, Part 10 is intended to supplement those requirements to which you're already subject. But I do recommend if you are subject to the Child, Youth and Family Services Act, if you're delivering services under that act, you should go review Part 10 of the Act and see what additional privacy obligations may be imposed by virtue of Part 10 coming into force. So with that, now that we've gone through a little bit of background on the evolution of Ontario's health privacy landscape in the last 12 months or so, where are we now? We're going to spend a big chunk of the remainder of our time today highlighting some of the key changes that we've identified in various privacy legislation and beyond which are listed on the slide right now. I should highlight these changes are by no means exhaustive. There are numerous other changes to legislation, which unfortunately we just don't have time to discuss today, but we've tried to pick some of the more pertinent and the far-reaching topics to talk to you about today. You'll see the first three are highlighted in red. And so those three hot topics are changes which are actually already in force in the legislation. So they are current as of today. The remainder are not yet in force. And so we'll get into what is coming on the horizon with those changes as we go along here. The first couple of hot topics we're going to discuss today deal with new penalties and enforcement measures under PHIPA, which were introduced very recently under Bill 188. So first up, Bill 188 has added a new section 61.1 to PHIPA called administrative penalties. It gives the IPC the authority to order administrative penalties against persons who have breached PHIPA or its regulation. This is a brand new power for the IPC. It represents a pretty significant expansion of the IPC's powers to enforce compliance with the legislation. So a very big change on that front. Now, there are some parameters around the appropriate circumstances for ordering an administrative penalty. The Act requires that the penalty be issued for the purposes of encouraging compliance with PHIPA or its regulations, or for the purposes of preventing a person from deriving any direct or indirect economic benefit as a result of a contravention of the Act or its regulations. While there is currently no monetary limit on the amount of the administrative penalty, which is a little bit scary potentially for some health information custodians, it has to reflect the purposes that I just mentioned, and it may be subject to regulations. So we do expect that the regulations are going to prescribe some further requirements and potentially some amounts, because the Act does state that regulations in respect of the administrative penalties may prescribe specific penalty amounts for different types of contraventions, including varying amounts based on whether the person required to pay the penalty is an individual or a corporation. So very important to know that both individuals and corporations can be subject to these new administrative penalties. Lastly, there is a 2-year limitation period on the administrative penalties. And that means that the IPC cannot issue a penalty more than 2 years after the most recent contravention on which the order is based first came to the knowledge of the commissioner. So next, in addition to the administrative penalties, the pre-existing penalties for offenses under PHIPA have been doubled. The list of offenses is found, as I'm sure many of you know, under section 72.1. So it includes things like the collection, use, or disclosure of personal health information in contravention of the Act, making certain untrue assertions, and making false statements to the commissioner, among other things. So with these changes, individuals can now be fined up to $200,000 for an offense, and corporations can actually be fined up to $1 million. So a pretty substantial increase there. Also new is the ability to sentence a person to up to a year of imprisonment for a breach of PHIPA, in addition to the fine. So remember, under PHIPA, officers, members, employees, or agents of corporations may be found individually liable for corporate offenses under PHIPA. These persons can be liable if they authorize an offense or knowingly refrain from using their authority to prevent an offense from being committed. They can also be liable regardless of whether the corporation itself is also prosecuted or convicted. So very important for individuals, and especially individuals in those positions within organizations, to be aware of the increased penalties and possibility of imprisonment now for commission of an offense under PHIPA. Lastly, on the deterrence front, in addition to the ability to order administrative penalties, the IPC's inspection and enforcement powers have been expanded. So Section 60 of the Act has been amended, and what that does is it grants the IPC a new authority to inspect records of personal health information without consent, where there's reasonable grounds to suspect that the record has been abandoned. In addition, a new Section 71.1 has been added, which allows a justice to grant a production order to any person to either produce documents, copies of documents, or data, or to prepare a document based on documents or data already in existence, where there's reasonable grounds to believe that an offense under PHIPA has been or is being committed, and that the document or data will provide evidence respecting the suspected offense. This order must be applied for by a provincial offenses officer, and the person who's subject to the order must have possession or control of the documents or data. So I want to highlight here that this amendment is a significant expansion of the IPC's authority under PHIPA, because it extends beyond just health information custodians. This can affect any person with custody or control of relevant documents and can really change the face of inspections now, which can be completed by the IPC under PHIPA. Finally, I did just want to highlight the last bullet point there, that PHIPA does now make it clear they've added a provision that the use of an enforcement measure under the Act does not preclude any other enforcement measures or remedies. So just because an organization may have received an administrative penalty from the IPC doesn't mean that they also cannot be convicted of an offense and subject to financial penalties, or where it's an individual that you can also be subject to the penalties plus imprisonment. So these things are not mutually exclusive. These amendments are very wide-reaching and a big game changer, and they show that the province is really stepping up its game in terms of deterrence measures to promote compliance with PHIPA and ensuring that any suspected breaches can be appropriately investigated. So next, on to access to personal health information in electronic format. A new section has been added to PHIPA, which provides individuals with an explicit right to access a record of personal health information in an electronic format, if the format meets the requirements, which are yet to be set out in regulation. The regulations may also provide for restrictions, additional requirements, or exceptions to the expanded right of access. This amendment is no doubt intended to facilitate greater access for patients to their health records, and depending on what the regulations ultimately prescribe, we could be seeing something similar to a right to data portability that's been seen in privacy laws in other jurisdictions. So it will be interesting to see what comes down the pipelines in the regulations. And this section is already in force. Like I said, no regulations have been prescribed yet, so we'll keep watching for those. So next, let's talk about de-identification. So as a bit of a background, de-identification is a concept that's contained in both PHIPA and FIPA, and it means removing information from personal information or personal health information that either identifies an individual or could be used either alone or with other information to identify an individual based on what is reasonably foreseeable in the circumstances. Now, in the most recent round of amendments to PHIPA, the definition of de-identify has actually been updated such that it will involve specific de-identification requirements to be set out in regulation. Importantly, FIPA does not have this requirement. No regulations have been proposed yet, but we're assuming that they're going to likely build on existing guidance from the IPC in respect of de-identification of personal health information, with a view to setting some minimum legal standards for health information custodians. Now, as a rule, privacy laws generally do not apply to de-identified information. However, that said, it is very important to note and highlight that de-identification does not make re-identification impossible. And so there's always some re-identification risk depending on the type of data and the context. In that vein, because there is always some risk of re-identifying de-identified data, organizations need to manage this risk by taking into account the context of any disclosures and any proposed uses of de-identified data. This may include consideration of the individuals who would be in receipt of the de-identified data and whether they can know if a certain person is in a data set. So one very simple example, because that all sounds like pretty technical jargon, a simple example of this is if a child participated in a survey and the results are released in a de-identified form, one risk could be the parents attempting to re-identify their child's responses and looking at the survey. So what are the odds and what are the chances that they would be able to do that? And that's, an individual contextual assessment that has to be undertaken. So to combat and deter re-identification, both FIPA and PHIPA have recently created new offenses for persons or entities who attempt to use de-identified information to re-identify an individual or to identify them. And this change is already in force under FIPA, but it's not in force yet under PHIPA. It could be that the PHIPA offense provisions won't come into force until there are some regulations regarding de-identification that are put in place, but we will be keeping an eye out for those updates. Now, the last topic I'm going to touch on today before turning things over to Kathryn is the introduction of a concept called consumer electronic service providers. This is a new concept in PHIPA, and these provisions are not yet in force, but they have received royal assent, so they are coming down the pipeline. And PHIPA essentially defines consumer electronic service providers as persons who provide electronic services to individuals at their request to enable them to manage and maintain their own records of personal health information. According to some commentary from the IPC, this amendment could be far-reaching and have a lot of impact in the health industry and for patients accessing their personal health information. For example, it can facilitate the use of apps by individuals to access copies of health provider reports and prescriptions, and that could then be stored on a smartphone. By the same measure, the amendments can give the IPC office oversight of apps that collect personal health information directly from the individual, for example, things like blood sugar readings, and this can give increased privacy protection for consumers who are using these products. Now, any health information custodian who provides personal health information to a consumer electronic service provider must comply with prescribed requirements and procedures. And the IPC will have the power to forbid a health information custodian from sharing information with apps, for example, in situations where there's concerns about the service provider's privacy policies or practices. So there will be some good oversight mechanisms built in there. It's also important to note that health information custodians who receive an individual's request for access to personal health information from a consumer electronic service provider are not necessarily required to provide the personal health information to that consumer electronic service provider. And these amendments are a prime example of PHIPA coming into the digital age and adapting to the increasingly prevalent use of technology in the collection, use, and disclosure of personal health information, and really an attempt to bring some rigor and some oversight to the use of that technology. So with that, I'm going to turn it over to Kathryn to take you through a few more hot topics, as well as how COVID-19 is impacting the privacy landscape in Ontario.
Thank you very much, Kristen, and good morning, everyone. The first hot topic that I'm going to address is our requirements related to electronic audit logs. This is one of those pet issues of the IPC and is an important mechanism to prevent and detect unauthorized snooping into patient records. And Kristen, if you could advance the slide, please. Thank you. The provision includes new requirements for health information custodians who are using electronic systems to maintain, audit, and monitor an electronic audit log. And the log must contain certain prescribed information, including the type of personal health information that was viewed, handled, or modified, the date and time on which the personal health information was handled or modified, the identity of persons who dealt with the personal health information, as well as the identity of the individual to whom the personal health information relates, as well as any other prescribed information as set out by regulation. Now, this is not a new concept. If you will recall, in 2014, the IPC had issued an order HO 113 relating to Rouge Valley, and that was the situation where there was the theft of records relating to maternity patients and the data being sold to entities outside of the hospital. And in that case, much of the decision deals with the need to ensure that you are able to effectively monitor health systems, and the electronic audit logging feature was a very big feature of that decision. It was caused some controversy at the time due to the difficulty with many older systems and those with numerous systems to be able to put those changes into effect. Many of those systems have limited auditing capability, and there is a significant cost associated with ensuring that those systems are built in and can capture all of that different information. So since that order, many health information custodians have been building capacity, and this is certainly something that we've seen in work with vendors that are working to ensure that their electronic audit log systems have those capabilities. But going forward, we do expect this to be a significant challenge for many custodians. And so from a risk management perspective, auditing your system capability is one of the key steps that you can take now to determine which systems you have, which collect, use, disclose, modify, retain, or dispose personal health information, to undertake a risk analysis and to prioritize which systems you should be placing your attention to first, depending on the sensitivity of the information and the use of that information. And that, of course, will have to factor into the increased cost, as well as exploring various audit solutions that may be available either on top of your systems or within your systems, and building something that can address these electronic log requirements. So there will be more to come on this. These changes are not yet in force. And so that's why it's the perfect time now to be taking an inventory and to determine what your plan will be going forward to address these when they these legislative requirements once they're in force. Kristen mentioned the Provincial Electronic Health Record and some of the changes that were actually introduced in Part 5.1 of PHIPA in May of 2016. These provisions have been sitting on the books for quite some time, and they are not yet in force, but there are a regulatory process in place to enable the proclamation and implementation of the electronic health record. The electronic health record is defined as electronic systems developed and maintained by the prescribed organization for the purpose of enabling health information custodians to collect, use, and disclose personal health information. And one of the questions that we've had for a long time is, who will be the prescribed organization? What is their role and their mandate? And under the proposed regulation, Ontario Health will be the prescribed organization. Personal health information in the provincial electronic health record will be shared among custodians who create or contribute personal health information to that record or collect personal health information from the electronic health record. Health information custodians will be permitted to collect personal health information from the electronic health record to provide or assist in the provision of healthcare to the individual to whom the information relates. So that should be familiar. That's the implied consent provision that allows health information custodians to collect, use, and disclose personal health information for purposes of healthcare and assisting with the provision of healthcare. It will also enable a HIC to collect personal health information where it has reasonable grounds that is necessary to eliminate or reduce a significant risk of serious bodily harm. And that's Section 40 of PHIPA that relates to those significant harm grounds. There are special definitions set out in the legislation relating to collection, use, and disclosure of personal health information in relation to the provincial electronic health record. For example, if you are viewing personal health information that is considered to be a collection by the custodian that is viewing that personal health information in the electronic health record. Individuals will not be able to opt out of having their personal health information in the provincial electronic health record. However, they may put in place consent directives, and there's a whole scheme that will be in place relating to how those consent directives are managed by Ontario Health. As Kristen mentioned, the proposed amendments that will enable the implementation of the electronic health record are set out in Regulation 32404 of PHIPA and were introduced on May the 26th, 2020. In that document, it names Ontario Health as the prescribed organization, which is responsible for the development and maintenance of the electronic health record. It addresses data elements that may be used to identify individuals when a healthcare provider requests or collects personal health information. There are breach reporting requirements to the Information and Privacy Commissioner in relation to unauthorized use or disclosure of personal health information through the electronic health record, as well as requirements relating to consent directives. The other regulatory amendments that we wanted to touch on are the amendments to Regulation 32404 under PHIPA that relate to digital health interoperability. And these, again, establish responsibility for Ontario Health to establish interoperability specifications pertaining to digital health assets with the direction and the approval of the minister. And as many of you will recall, both through the Ontario Health team, digital planning, and in your service accountability agreements, there are provisions relating to digital health in your funding agreements that will require you to comply with such specifications and policies as are developed by Ontario Health and the Minister. The Ontario Health will also be responsible for compliance monitoring and a certification process to ensure that various digital assets meet those specifications that are set out in the regulation and in the associated policy. The amendments will also require health information custodians to ensure their own compliance with these specifications for digital assets that you select, develop, and use. And so again, this is intended to ensure that we can have digital systems that will be able to be used across the province and regions, and they'll be able to talk to each other as we move forward with integrated care and Ontario Health teams. Finally, there will be requirements to provide Ontario Health with reports and to assist the agency in supporting compliance monitoring. The enforcement of these provisions will be by means of complaint to the Information Privacy Commissioner. Along with the draft regulation, the ministry has also provided a digital health information policy, which has been released with the proposed regulation. Both of those documents are open for comment until July 22nd, 2020. The draft policy will include information on the interoperability specifications established by Ontario Health. It will encourage health information custodians to use existing resources and supports to guide digital health asset modernization. It will require health information custodians to comply with the regulation, and it will be ensure that the specifications will increase the security and the reliability of solutions. Our next hot topic relates to PHIPA reporting obligations. And as you know, there is currently an obligation on health information custodians to notify the IPC of a theft, loss, or unauthorized use or disclosure of personal health information in certain circumstances. And the circumstances are fairly broad. However, the legislation is silent as to the timing of notification. The proposed amendments will clarify that the report is to be made at the first possible opportunity. And I've underlined first possible opportunity because, in contrast, the obligation to notify the individual of a breach, which is found under PHIPA, is at the first reasonable opportunity. So conceivably, this is a requirement that would require notification to the IPC even before you notify individuals when that notification is required. Proposed amendments to the regulation will also include additional annual reporting requirements related to the number of times that personal health information was collected by the custodian from the provincial electronic health record without authority. So that's another category of information that will need to be collected in addition to the other statistics related to stolen, lost, or other breaches relating to use without authority or disclosure without authority in relation to the custodian's own PHI, which is in your custody and control. Number 9 relates to data integration. And there has been a recognition of the siloed nature of the various ministries that are involved in the provision of healthcare and related social services. And so the desire for public sector organizations to be able to share or link and analyze data in order to support policy development, system planning, resource allocation, and performance monitoring has become very evident as we move forward with health system integration. And an example of that relates to the autism services, which are provided by a mixture of health information custodians and service providers under the CYFSA, as well as there could be institutions that are subject to PHIPA. So there are amendments to PHIPA, FIPA or MFIPA, and the Child, Youth and Family Services Act to create and facilitate the sharing of data by or among inter-ministerial data integration units, extra-ministerial data integration units, and ministry data integration units. And essentially, this will allow for the collection and the sharing of personal information for certain established processes and subject to established rules. And, as it relates to managing and allocating resources and planning for the delivery and evaluation of government programs and services. There will be a number of privacy controls that are also in place relating to data minimization, which is a fundamental concept, of course, of privacy laws, that we minimize the amount of personal information that is collected, and that there will be mandatory breach reporting, and the Information Privacy Commissioner will have review and order-making authority as it relates to the integration units. So our next topic is not grounded in legislation, but really relates to cybersecurity. And there have been several alerts that have been issued by the Canadian Centre for Cybersecurity relating to cyber threats to health organizations. And there has been identified elevated risk to organizations that are involved in the national response to COVID-19, including medical research, manufacturing, distribution, and policymaking, as well as to health organizations that are delivering care. The concerns that have primarily been identified are the risk that data may be stolen, either intellectual property relating to COVID-19 or sensitive information related to Canada's response, as well as risk from cyber criminals who may take advantage of the COVID-19 pandemic to target health organizations to extract ransom payments. Now, this is not new. Even before COVID-19, there had been a significant increase in ransomware attacks on health organizations, but it is recognized that the impact could be more severe during the current pandemic, both because of the accelerated and widespread use of virtual and telehealth technologies, many of which have been implemented very quickly, and the need to expend resources to address the COVID pandemic directly. There are a number of recommended actions from a risk management perspective that we suggest that you consider in adopting and engaging in cyber defense best practices. So this includes awareness of phishing activities related to COVID-19, ensuring that you have security policies in place for employees who are working from home, increased monitoring of your network logs for significant threats, ensuring that you are updating your systems and critical systems for security vulnerabilities. One of the key risk management tools for addressing ransomware is to ensure that you have an effective business continuity plan with backups and infrastructure redundancies that will enable you to keep functioning in the event that there is a ransomware attack that makes your systems inaccessible for any period of time. Privacy impact assessments and threat risk assessments are always recommended when implementing new technologies. And even though organizations are moving very quickly, the need to ensure that those measures are taken to protect the privacy and security of personal health information are still there, and ensuring that you've done your due diligence either before, or if you haven't done that, making sure that you have done those system analyses to ensure that you have protections in place. And then finally, contractual agreements to ensure the protection of personal health information, particularly when you're dealing with third parties, and ensuring that you have mechanisms in place to ensure that a similar level of protection is in place when personal health information is being handled by third parties. A second cybersecurity alert was circulated by the Canadian Centre for Cybersecurity Alerts, and this relates to considerations when using video teleconference products and services. And the migration and it provides mitigation and guidance when using VTC software. So some of these are fairly straightforward, including using existing corporate solutions when possible, ensuring your platform has appropriate security features. Some of the concerns, of course, have been vulnerabilities related to third-party infiltration or hijacking of VCT sessions, the so-called Zoom bombing, or similar attempts to compromise systems that are set up to enable remote communication or communication from a distance. There have been some very quick improvements to some of the products and software that's available. So ensuring that you are using the latest version of software, and are using the mechanisms that are in place, passwords, and meeting rooms, so that you are using the full potential of the privacy and security measures that are built into those solutions. For our last little time together, we are going to talk about privacy amid COVID-19. Privacy laws continue to apply during this time, but there is recognition by federal and provincial privacy commissioners of the exceptional circumstances. So one of those being the acknowledgement by the IPC of the potential inability of organizations to meet response timelines when dealing with access to information requests or requests for correction of information. PHIPA already has provisions that allow for an extension of time when responding to an access to information request in light of extraordinary circumstances. And that is something that you can certainly take advantage of, where responding to a request will interfere with the ability of the organization to undertake business. The IPC will also consider those circumstances when evaluating appeals relating to deemed refusals. So those are situations where, because you haven't met the timelines under PHIPA, the health information custodian or institution, I should say, is deemed to have refused access to the request. The IPC's office is actually closed currently, but they are responding to breach notifications, and there are individuals who are working from home. And there's still an expectation that privacy breaches will be reported in the usual course. An emergency order was issued under the Emergency Management and Civil Protection Act as well, which freezes time limits for initiating complaints or appeals to the IPC that are set out in the various privacy statutes that are within their jurisdiction. They also applied to time limits for third-party appeals, where a third party is affected by an access to information request. The institution should ensure that they are not releasing documents pursuant to that may be subject to a third party exemption without ensuring that there is sufficient time to appeal. Just wanted to touch on a few other issues, one being sharing information with the medical officer of health in relation to COVID-19. Of course, there are mandatory reporting obligations of positive and presumptive cases of COVID-19 under the Health Protection and Promotion Act. And we did want to highlight that the legislation permits health information custodians to disclose personal health information to a medical officer of health or the chief medical officer of health, where the disclosure is made for the purposes of the Health Protection and Promotion Act, which is very broad and includes addressing and managing public health and communicable diseases. There's also the ability to share information if there are reasonable grounds to believe that disclosure is necessary to eliminate or reduce a significant risk of harm. I think I will skip the next slide. This just relates to some of the databases that have been created to deal with aggregated provincial cases. And I will go to the next slide, which relates to privacy relating to contact tracing and similar apps. As you may know, there was a joint statement that was issued by the federal, provincial, and territorial privacy commissioners that relate to contact tracing and the use of smartphone apps as a public health tool. The statement is only a couple of pages long, and it sets out principles for governments to follow to address privacy risks associated with these apps. And I just suggest that it's a helpful document to look at when looking at how you balance privacy risks against other goals, in this case, public health and the type of analysis that comes up very often when you're dealing with use of video technology or use of other tools that have other purposes but have privacy risks associated with them as well. So in summary, there have been enormous changes to the privacy environment to address health system transformation, digital health modernization, and expand data sharing capabilities. COVID-19 has really accelerated the use of digital platforms and virtual care and innovation, and has also potentially exposed health information custodians to additional areas of privacy risk. The enhanced powers and authority of the IPC that have been put in place through legislative amendment are really intended to ensure that there are tools in place for the Commission to be able to address privacy risks, including increased penalties when there are offenses under PHIPA. And I think we can expect that these changes will continue as Ontario prepares for the continued integration of health systems, and we continue to move forward with digital health in this province. We want to thank you for attending our session today. The presentation slides will be circulated to participants along with a copy of the presentation. And we do encourage you to reach out to either of us if you have any questions relating to any of your privacy challenges. Thank you very much and have a great day.